I've been asked to talk about a leadership journey, so I have to say that compared with Michelangelo as a child, I'm not sure that when I went to school on the first day I really understood what my vocation was to be in life. And I would never have thought that I would be here doing this talk called Professor Elder and have had the clinical opportunities that I've had. But I'm a paediatrician, so you're going to find a lot of references to childhood in this talk. I started out in paediatrics in 1984, having done some house surgeon years and had some time overseas. I didn't have grey hair then. And I just put the list on the side there of the way we go through a system in medicine. Now, I'm talking from my perspective as a doctor, but those of you who are in other aspects of healthcare and even management will have your own systems of training and the way you go through things. And the thing about this list is that there's always somebody behind you. You know, as a trainee intern, you love it that you're not a fifth-year medical student anymore. But there's always somebody ahead of you. And so because of this, we all have a responsibility to look after the people behind and respond to the people ahead of us. I had two really important mentors early in my career who many of you will recognise. One was named Dame Norma Restio, who I first met as a fourth-year medical student on Dominion Ward in Dunedin Hospital. It was interesting, at the time I was a student, a neighbour over the back fence in Gore was in hospital in Dunedin. And I went to see him and he said that he felt that he was being very well looked after, but he hadn't seen the doctor yet. And so 2 days later, I went back and said, "Have you seen the doctor yet?" And he'd worked out that the lovely social worker who was coming to see him was actually his cardiologist. It was a sign, I think, that Dame Norma Restio was a good communicator. I later went on and was house surgeon for Norma Restio, and she was fantastic because I always knew how I needed to perform. I needed to know the potassium, I needed to know my patients, I needed to be there in the morning. The only excuse for not knowing your stuff was to have had a cardiac arrest 2 minutes after you arrived in the hospital. As a consultant, when I first was working in neonatology, I tried to see if I could get that going with my team, and I wasn't sure ever that I achieved it in the way she did. And maybe it is this talk of old school. It wasn't that she told anybody off, it's just that you really wanted to perform for her. And I still see her occasionally because she comes to the festival most years, and it's always a great pleasure to see her, and I appreciate all she gave to me. David Holdaway was the other person. He was a paediatrician in Dunedin when I was training in paediatrics, and what he taught me was about how to communicate with patients, and particularly parents of patients. And I had seen other people I've been taught by people who, when we were students, sort of did a bit of an eye roll because the patient had a list of questions. You know, they get a bit like that, they said. This is a person with a serious oncological disease. But with David Holdaway, he said to the parents, go and buy a notebook and write down everything you want to ask and bring that notebook along to the next clinic. So that was a really important lesson for me. The other person who I was a mentor way later in my life was the first professor of paediatrics in Wellington here, the famous Jeff Weston, well known to my friends, the paediatricians in the audience. And the thing about Jeff Weston is he never really retired. He used to appear at my door and ask me if I was organising something for a little thing he'd handed on to me, the Eric Bernard Trust. He was always checking that I was doing my job in the very nicest, most inoffensive way. But he was a great advocate for children, and that's what he taught me about. And this picture is a classic of him because he would have talked to the most important person in the room, and this was the then Minister of Health. Sadly, 2 of my mentors have now died, but the woman is still going strong. How about that? So my clinical work has been first in neonatology, and then I morphed into a paediatric sleep physician, and there's a story on that. And so when the Health Quality Safety Commission has the day on burnout, you can invite me to be a speaker. The odd thing about changing from neonatology to sleep physician, when you're a paediatric sleep physician, the parents aren't sleeping, but you are. When you're a neonatologist, the parents are sleeping, but you're not. The other thing that I've done all along is to work in child protection, and that started out because I was a woman, and it was decided if you're a woman training in paediatrics, then you can look at children who've been sexually abused. And as time has gone on, I've got more involved in the bigger picture of family violence. So how my clinical career has gone: on the academic side, you go through the promotion scale, if you're mad, and then on the right side, on the clinical side, having a joint clinical academic post, I've worked as a consultant, and as I've got higher on the other side, they seem to think you might be more useful on the Child Health Governance Committee and starting up a child health research committee. And in the community areas, my work with the PMMRC, the Family Violence Death Review Committee, and other things related, mostly to child protection issues. So in doing this talk, I've wanted to reflect on what is clinical leadership, and of course this has already been discussed a bit. And I decided that one of the things about clinical leadership is doing your job well, getting on with it, but with lots of people watching you. And that's why I think that hierarchy is so important, because the fifth year is watching the TI is watching the house surgeon's watching the SHO, etc. And so it's everybody's business. And so we have to have our knowledge, the knowledge that is required to fulfil our role. We have to be good communicators. I was just sitting in the ED recently with a friend of mine who had a couple of visits to ED in the weekend, and there were some people who knew me who came in, and they were people that had gone through our med school, so I thought they were quite good actually, but it might have been just because I was sitting there. There were other people who didn't know me, and there was good and there was bad communication. Some of it was quite condescending, I thought. Once you put a person lying down, not with their usual clothes, not in their office, it's interesting how there's a difference in the way people can talk to them. I think it's really important that we act the way we want others to act. That can be in our dress, in our manner, the whole way we conduct ourselves. We need to be accessible to the people below us, the people above us. We need to be able to address issues of performance in a way that is really, can make it a learning. I have a really good memory of an episode when I was training and working in Perth, West Australia. And we had a resuscitation that was very difficult on a young child, and the child died, and we didn't do it well. And the head of the ICU talked with us all individually, and at the end of that talk, we didn't feel like we had to give up medicine and go and do another job. We knew where we'd gone wrong, and we knew how to do it better. But we still felt that we could turn up for work the next day. And I remember thinking at the time, that is quite an amazing skill to have, and I don't know that I'm very good at that. But it's really important if we're going to train people and help to learn from mistakes. And so we also have to express appreciation, even for the smallest things. This is one of my pet things at the moment, because I teach medical students a lot and we're in small little groups. And if they start texting, I do have a tantrum, and it really annoys me. And yet I go to the clinical meeting in our department on Friday, and what are all my colleagues are doing? They can't keep their hands off their phone and they're checking their emails. So what are you modelling? Your junior staff member is at the front, and they're trying to present a case to you. They want your advice and you're on the phone. So I think that's a really important issue to think about. What about the domestic violence issue? This is a really big problem. You should all read the Family Violence Death Review report that was produced last week, because it has a lot of information for people in health. So what's your attitude going to be on the wards or in the situations that you work in or in your management role? Are you going to say the Family Violence Intervention Program is a waste of time, it takes everybody off a floor, I'm not going to ask about I can't do that in my clinic, it's a complete waste of time. You could discuss that with your junior staff, or you could say on the ward round or the situation that you're in, I'm really worried about that woman, she looks really sad and I noticed that her partner hasn't left her alone. Can you just go back later on when he's not around, or can you get one of the nurses to just talk with her and find out what's going on? You don't have to do it yourself, but you do have to role model it. So the other bit of clinical leadership is when you are in charge, when you're not just everybody, and sometimes it feels like you're sorting out everybody else's problems, and that's part of it, but it's other things as well. And these things have already been discussed today about knowing the role, knowing what your job is, making time for it. In our institutions, we often add the leadership roles onto all the other work you're doing, but you actually need to take time to do it, particularly in this day and age. We have to have trust, and I have to trust that when the staff that I supervise are not seen for 2 days, that they actually are working somewhere. And they have to trust that when I say, please tell me where you're going, that it's for a reasonable reason, like if there's an earthquake and I have to count the bodies, it'd be quite nice to know that you're not in a meeting in Auckland and I don't have to count you today. So there are practical reasons why we need to keep tabs on people. We need to have respect, and you can't demand respect. You have to be the kind of person that people want to respect, and that you have to be competent in your role, you have to be consultative, you need to self-regulate yourself. This has already been mentioned. I think the thing that I have learnt the most since I've been a head of department is if an email makes you really angry, leave it for 48 hours. Sometimes you can do it in 24 hours, but 48 hours, 24 hours you've stopped being angry, 48 hours it's usually not a problem anymore, and you don't even have to address it. So that's my little pearl of wisdom. And the other thing, I think the job is of the leader, and this hasn't been mentioned. We've talked about teamwork and working together and leading from behind, but what about staff wellbeing? I think it's really my job. In the past, when I had a period of burnout, I didn't really feel people stuck up for me, and I don't expect my staff to work 9 to 5, but I do expect them to be able to do their job, and I do expect them to have good mental health, and I think that's a really important role that we have to think about. So advocating for your group. And then there's the whole thing about stepping up and being an advocate because you're in a leadership role. And I like this quote from Edward Said, that the intellectual, he talks about the intellectual, but I think you can put the leader in this as well, is an individual endowed with a faculty for representing, embodying, articulating a message of view, an attitude, philosophy or opinion to, as well as for a public. And this role has an edge to it. It can't be played without a sense of being someone whose place it is publicly to raise embarrassing questions, to confront orthodoxy and dogma, to be somebody who cannot easily be co-opted by governments or corporation, and whose raison d'etre is to represent all those people and issues that are routinely forgotten or swept under the rug. And this is quite a good quote for paediatricians, because we often feel that the children in our country are being swept under a rug. So we ask questions like, there's a lot of money being spent at the moment on our flag. The polls tell us we're probably not going to change it. But we've got little children that have got empty bowls in our country and don't have food. We've got people who come to our clinics from the car that they're living in. And it just seems pretty disgusting to me. And we've got this, our Minister of Finance was talking recently about all the money being spent on domestic violence and what a waste it is. Yesterday, in our multidisciplinary team meeting, we decided to put alerts on 19 children. That's just in our DHB, just on this week, this Tuesday. But a child protection alert takes about 2 hours work. So that's a whole job for somebody for a week. And we don't have the time to actually do that with the resources we have. And yet my medical students, I'm getting messages, we don't know if little Johnny Bloggs can go to Wanganui because he hasn't had his police check yet. So we're checking all these people to see if they're safe to be with children, and we don't have the resources in our hospitals to process the children who really are in need. So we have to rethink, I think, how we spend our money. I also have this little thing about paediatrics and the curriculum, because if you work out the average lifespan, the paediatric age range is about 20% of the current lifespan in New Zealand. Therefore, paediatric teaching, I think, should be 1/5 of the curriculum. That's 1 out of 5 years. We have 10 weeks in 5th year and 4 in 6th year, and that is the highest of any medical school in Australasia. How sad is that? When all the diseases that you people dealing with adults are dealing with mostly come out of childhood. Certainly in New Zealand, a lot of the mental health and other issues come out of a troubled childhood. We also have to teach them from 24 weeks gestation to adolescence, and that's pretty tricky too. So can we grow clinical leaders today? Well, this is what we probably think of the youth of today. From the day your baby's born, you must teach them to do without things. Children love luxury too much, they have execrable manners, they flaunt authority, they have no respect for their elders, and I'm an elder so I know. They no longer rise when their parents or teachers enter the room. What kind of awful creatures will they grow up to be? Well, that's what Socrates said. So it all starts in childhood, and that's where we grow good leaders, in my opinion. I'm not saying I'm a good leader. I have my moments, but I haven't quite got there yet. But that scrubby little urchin on the left is me when I was little, and I was lucky because you can see I was living in a beautiful part of New Zealand. I had 2 parents who loved me. They had enough money to feed me, and they had enough money to educate me. There's a lot of people that I see in my clinics who don't have that opportunities, and it's not a level playing field in New Zealand, and we have to make it better from that point of view. So I'm going to quote a guy. I don't mind. You can quote me, I'm a woman, so if you want to quote a woman, quote me. But Albert Schweitzer said, there are only 3 ways to teach a child. The first is by example, the second is by example, and the third is example. I've learned from bad examples, and I've learned from good examples. In New Zealand, our children who grow up in family violence they learn from bad example. But we want to create a world where all our children and our junior doctors and our junior nurses and everybody can learn by good example. So I just want to acknowledge that the 2 people who pay me are the University of Otago and Capital Coast Health. Thank you very much.